I do 12 workshops a year that go around to smaller communities, and we bring in medical professionals such as myeloma specialist doctors and myeloma specialist nurse to people that don't normally have access to that. They can go up to the doctors and say, "Hi, I'm Joan. This is what I feel like's happening. Why are they putting me to this treatment?" And the doc will spend the time with them. These meetings aren't 300 people. They're normally 75 to 100 people. So the doctors have a chance to talk to people. I met a patient in Kansas City. She's now had it 21 years. She fully is on the IMF boat, and she says that all the training that we brought in those regional community workshops has been a guide for her treatment. So she's had time to go to several of these workshops and talk to several different doctors. And those doctors are very forthcoming and very helpful. Some of the doctors, some of them are so busy they can't, but they exchange emails. They become their go-to for the doctor. This new hematologist or oncologist goes, I can treat this, but let's work with your local doctor. And that's something that's fantastic, because the local doctor can get up to speed while the specialist is feeding information to the local doc and helping him feel comfortable, and the local doc can call and ask. That's something that I've never experienced in my entire life of watching that interaction with the patient. And when that patient gets someone else on his support, he has the IMF info line, he has us support group directors, some of them even have access to Dr. Jury, and many have access to these doctors I brought along. There's a lot of interaction at registration. The doctors come down, I'll say this guy's new, and he'll go say, "Hi, I'm Dr. Rafat Abanar, a well-renowned doctor in the myeloma field," or "I'm Dr. David Wiesel from this institution," or "I'm Dr. Craig Cole from Detroit at the Michigan State University." My goodness, you bring these people here to help or talk to us? Absolutely, we bring them here. Absolutely, it's important for you. Absolutely, you should come. Now, if you're shy, we'll put you off in the corner, and I'll be there to help you. If you want to participate, join in the crowd, raise your hand. But we have a seat for every person that's dealing with myeloma, whether they want to deal with it or not deal with it. I have a seat for them. I'm down in the dirt with the patient, so are my colleagues. And that's the difference with the IMF. Good morning, everyone. My name is Kelly Cox, and you are here at the first IMF virtual regional community workshop. I want to tell you thank you for taking time out of your Saturday. I know that some people in the fall are raking leaves, and out here we're just steaming away in California, hoping for no fires. But I am the IMF Senior Director of the Regional Community Workshops, and what you just watched was the RCW video talking about what we're going to accomplish today. We usually meet in person, but because of all the COVID and all that stuff, we're doing this virtual. So you get to ask the doctors questions that will be available on your screen. You'll see the first talk is going to be about Myeloma 101 with Dr. Godby. She'll be talking about a couple other topics. But I want to go over some housekeeping here. You'll see, I'm going to read off of a prompter here. You'll see on your screen at the bottom of it are multiple application engagement tools you can use. All engagement tools are resizable and movable, so feel free to move them around to get the most out of your desktop space. And that will allow you to see the images better and the charts and things like that. You can expand your video area or maximize it to full screen by clicking on the arrows in the top right corner. I'll repeat that. You can expand your video area or maximize it to the full screen by clicking on the video and the arrows in the upper right corner. Now, if you have questions during the webcast, you can submit them through the Q&A engagement tool, which would be somewhere on your right or wherever you've moved it. We will try hard to answer these during the webcast, but if a fuller answer is needed or we run out of time, it will be answered later in an email. Please know we do capture all questions. This will be used for future reference. A copy of today's slide deck and additional help materials are available in the resource list. or at myeloma.org. When I'm talking about everything about the IMF, I'll be talking about myeloma.org. We picked that website 30 years ago, and this is our 30th year in operation. We're the oldest multiple myeloma foundation in the world. Now, a copy of this slide deck, as I said, will be on myeloma.org, but you can also get that the day after with your email that we sent to you saying that you were welcome to the meeting. You can hit the same link a day later, or you'll be getting an email. So you have multiple aspects to get back to this talk. I'd like to take the time to thank our speakers, or not our speakers, but our sponsors that graciously has helped us out this year. Amgen, Janssen, Binding Site, Bristol Myers Squibb, Karyopharm, Takeda Oncology. These folks have been with us for many, many years and work with us to make sure that the proper information, proper words, proper charts are out there for your review and discussion. Now, each one of these sponsors I spoke about are linked on our website, and you can go to the website at myeloma.org, sorry to be repetitive, and tap Amgen or Janssen or Binding Site or Bristol Myers Squibb, Karyopharm, or Takeda from myeloma.org, and it will lead you to additional opportunities that are presented for you there. Today, you see a picture of me, Kelly Cox. That's the guy with the gray hair, and it's getting grayer. Luciano Costa and Kelly Godby from University of Alabama. I just love saying Luciano, and you can imagine I love saying Kelly, because that's who I am. And Beth Feynman from the Cleveland Clinic. They'll be speaking today. You have 3 incredible speakers that are going to help out and get you through some myeloma headaches. The purpose of this is to get you to a place that you as a patient, as a caregiver, or a support person for your myeloma have a much better understanding of it. It's critical that you just don't gloss over everything. You have to pay attention. Get a notepad out right now. Get a pen or a pencil, or whatever way you write things down, because there will be a question and answering moment or two, and I want to get your questions up there. It's important that you guys ask questions. I believe there's about 50 people on the call, so we should be able to handle this right now. The call seems to be going up in numbers as I speak, and I think that you'll find this very, very, very good. Let's go over the agenda. We're doing the welcome and announcements. I'll add a couple more announcements. The first talk will be by Kelly Goodby, and it will be frontline therapy, Myeloma 101 and frontline therapy. I got that backwards, sorry. Then there'll be a question and answer series with the panel. That'll be with Kelly and Dr. Luciano Costa. And they're both from University of Alabama, Birmingham. Then we'll have questions about his talk, and then we'll go on to living well with myeloma, and that will be at Beth Feynman. I failed to mention Dr. Costa is going to be working on relapse therapy and emerging therapies and clinical trials. All of these topics, even though you think you might be a myeloma intelligent the most, whatever the word would be, you can always learn something. And I hope from the support group leaders that are participating, I see, is it Tiffany's participating, Thomas Good's participating, Nancy Bruno's participating. This is great information to take back to your support group and replay. So we're here to help you do so. We want to do so, and we look forward to you doing so. As I said, Myeloma 101 is going to be played right now in a second or two, but I wanted to say one more thing about what's going on here. We have a table read coming up October 19th? What? 23. Thank God I have Amira here and her lovely husband Miko helping me in the background. We could not do any of this without them. And on the 23rd, we have a reading with the Ray Romano cast from Something About Raymond. We have done this for years. It is a hoot. It's a hoot. So if you have to spend any time on a Saturday night, is it Saturday night? Friday night, this might be good. So go to myeloma.org and look at our website, and it says the Comedy Night Table Read. We'd just love to have you there. So without further ado, sit back. Remember, get your pencils and pens ready and your notepads. And let's have Kelly Godby MD, University of Alabama, Birmingham, talk about Myeloma 101 and frontline therapy. Thank you, everyone, for participating. Take it away, Kelly.
Everyone, I appreciate you attending this morning's session. I am Kelly Gabi. I'm a physician at University of Alabama at Birmingham. We actually started, Dr. Costa and myself, about 7 years ago, the multiple myeloma clinic here at UAB. And I'm excited today to present to you the basics of multiple myeloma, as well as the treatment for newly diagnosed patients. Multiple myeloma is a cancer of plasma cells. Plasma cells are part of our immune system, and their normal function is to make antibodies to help fight infection. However, in the malignant state, these antibodies or these proteins do not help us, but instead they go around and harm various organ systems in our bodies, including our kidneys, as well as the presence of the plasma cells just being in the bone marrow cause anemia and other organ dysfunction. We'll go over each of the organs that in particular are targeted in patients with multiple myeloma. Multiple myeloma is a set of criteria, so it's slightly different than most cancers in the fact that you just don't biopsy a particular organ and say, yes, you have this malignancy like most of us think of breast cancer with a breast mass. Instead, you have to meet 3 criteria and to actually have multiple myeloma or symptomatic multiple myeloma. The first criteria is that you have a circulating protein either in your serum or in your blood or in your urine. The second thing is 10% plasma cells or greater in the bone marrow. And then the last thing is CRAB criteria, which is actually the end organ damage related to the plasma cells being present in the bone marrow, or the abnormal protein in the circulating in the blood. So CRAB stands for calcium, high calcium levels. R stands for renal or kidney dysfunction. A stands for anemia, and B stands for bone disease. In 2014, the International Myeloma Group decided that there were 3 other characteristics that if a patient had put them at such high risk for going on to develop multiple myeloma that they should be treated as myeloma patients. And these 3 characteristics are having greater than 60% plasma cells in the bone marrow, a free light chain ratio greater than 100, as well on advanced imaging, whether MRI or PET-CT, 1 or more lytic lesions. These patients within either of these 3 criteria had approximately 80% risk at 2 years of developing multiple myeloma, so now they're considered myeloma and we treat them with chemotherapy. Myeloma is really a spectrum of illnesses related to plasma cells. There are preceding states. The first preceding state I would like to discuss is MGUS. MGUS just means that you have the abnormal clonal protein in either your blood or urine. And about 1% of patients with MGUS go on to develop multiple myeloma per year. So it's a fairly common condition to have MGUS. However, only a very small proportion over the course of lifetime ever go on to develop multiple myeloma. But we do know that every myeloma patient had preceding MGUS prior to developing multiple myeloma. The in-between state is smoldering myeloma. So these patients have the abnormal protein or have at least 10% plasma cells in their bone marrow. These patients, because of the higher percentage of plasma cells in their bone marrow, as well as the higher amount of protein in their blood or urine, are more likely to go on to develop multiple myeloma, and their risk is approximately 10% per year. So therefore, at 5 years, the risk is approximately 50%. Currently, we do not treat MGUS with any sort of intervention. Smoldering myeloma, there's a growing robust body of literature to see whether or not there's a potential benefit for those at the highest risk, whether or not they would benefit for treatment. Multiple myeloma affects approximately 30,000 people in the US per year. It represents 1% of all malignancies and 10% of all hematologic malignancies. Unfortunately, approximately 12,000 patients die with multiple myeloma per year. I just wanted to point out a couple of things. The preceding condition, MGUS, is very common as we age. Approximately 3% of Americans over the age of 50 will have MGUS. But remember, myeloma, even though it affects 30,000 individuals per year in the US, is still considered not necessarily a rare cancer, but it's relatively uncommon when you compare it to prostate, breast, lung cancer. And the average age of diagnosis is late. So like in the late 60s, so 67 is usually the average age. You can see approximately 30% are diagnosed between the ages of 65 to 74. So how are our patients diagnosed? You can think of the Crab criteria or the organ dysfunction, but actually very few patients in my clinic now present with an organ damage as their first manifestation of their disease. Often because of the preceding MGUS state, physicians find the abnormal protein or the MGUS and routine workup for just normal labs. And then they find anemia, or they find kidney dysfunction, or they find high calcium levels. So the patients can present with bone pain, approximately half. This is due to the bone lesions associated with multiple myeloma. About half can present with renal insufficiency, or their kidneys don't work well. Anemia, and about 3/4. And high calcium, because the patients who have myeloma, they often have these bone lesions, as we mentioned, approximately half, and our bones are made of calcium, and if our bones are being destroyed, then it results in high calcium levels that are circulating in their blood. If you have high calcium levels, it can cause fatigue and increase urination as well as confusion. So what are the risk factors? Myeloma is higher. The risk of getting myeloma is higher as we age. We mentioned the average age at diagnosis was 67. Sex is slightly more common in men than women. Race, it is 2 to 3 times more common in people of African ancestry. Family history. If you have a first-degree relative like a mom or brother or sister who has myeloma, then you're 3 times more likely to get multiple myeloma. Environmental causes are actually usually hard to establish, but there has been an association with excess exposure to pesticides or radiation. And I didn't include this on the slide, but there's been a growing association with obesity. So what about the initial testing and assessments? So I have listed all of these laboratory values here that we must check on a newly diagnosed patient: CBC, chemistry, LDH and albumin and beta-2 microglobulin are important because they're very important for prognosis. The levels of the antibodies, as well as the traditional myeloma labs of the serum protein electrophoresis, the serum immunofixation or SIFE, the urine protein electrophoresis, the urine immunofixation, and the serum free light chains. I consider those 5 the essential myeloma labs that we use to follow a patient's response to therapy, as well as important for the initial diagnosis at baseline. Every patient should know, at least I believe, every patient should know what their baseline myeloma parameters are and should be able to follow those monthly while on chemotherapy. The labs, unfortunately, can cause a lot of communications, both for other physicians as well as patients and their family members. I just try to simplify it and say M protein, or the M spike, stands for myeloma protein. It's just a measurement of the aberrant protein that the plasma cells make. It can be detected in either your blood or urine. And it's done by what they call serum protein electrophoresis. And so simply they separate all the proteins in your blood based off size and charge. And from that, they're able to see if there's an aberrant protein present. As you can see on the bottom here, this is the gel electrophoresis of a patient. And you can see this red spike, which is indicative of a M protein or M spike. It is a quantitative test, so it tells you how much aberrant protein is there. It does not tell you the exact type. Every antibody in our blood consists of both a heavy and a light chain, which is how it neutralizes the infection. You can measure the entirety of that abnormal protein, or you can measure the individual components. So it's important to identify the specific type. There are 10 possible types. The most common is IgG kappa. And the way to identify that is by the serum immunofixation. The serum immunofixation is simply using a protein to detect a protein. And you can see in this particular individual that they were IgG lambda. So you would measure, you could measure the IgG individually, as well as the lambda or the free light chains, in addition to the M spike, to see what their response to chemotherapy would be. You can also measure the abnormal protein in the urine. This is called a UPEP. It's the exact same technology. I know this is not a favorite test, but it's best done on a true 24-hour urine to discern the total amount of protein. If there's aberrant protein in the urine for myeloma, it's called Bench-Jones protein. The free light chains are also important. It's another way to measure the the protein burden in the blood related to the myeloma. About 15 to 20% of myeloma patients only excrete light chains only. And it's very important to follow this going forward, and it should tell the similar story to what the M spike. If there are discrepancies, there's a phenomenon called light chain escape, where people, even they originally made heavy chain, they make the light chain only. Radiology tests are extremely important because of the bone involvement in multiple myeloma. The standard test used to be a skeletal survey or a metastatic survey, depending on which institution the name varies. And clearly you can see here, is represented by the yellow arrows, that the bone, instead of being nice and white and solid, has these little black holes. And these are the lytic lesions, which is actually a loss of bone in those areas. However, this test is not very sensitive. You have to have lost 30% of the cortical bone in order for this test to be positive or to show lytic lesions. So now we currently do more sensitive imaging modalities, and this is what lytic lesions look like on those 3 imaging modalities. This is a CAT scan, and you can see this is a patient's spine, and instead of being the white bone, you see these little black dots, which is a lack of bone in those areas. On an MRI, the same view as this person, but here's the spine again, and you can see that the bone is very heterogeneous with these myeloma bone lesions. And then lastly, on a PET scan, a PET's looking at a different measurement. It's not actually looking at the architecture or the structure of the bone. It's looking to see if there's increased uptake, or FDG avidity. And so what it's measuring is how active the marrow is in those areas, and if there's potential hypermetabolic lytic lesions. And so you see these darkened areas in the bones, whereas this is what a normal bone should look like on a PET survey. And you can see in this individual that there's several dark areas in both the arm, as well as the spine, as well as the rib cage. This is actually a patient who had myeloma, who had a wonderful response to treatment, because you can see their PET scan completely normalized after therapy. Bone marrow. I have performed a lot of these in my day, but I always consider the patients an expert because they've actually undergone the test. It is essential to have a bone marrow biopsy in order to confirm the diagnosis, but a lot of special genetic information is derived from this, and we'll talk about on the next slide. This is what a typical plasma cell looks like, and this is what the pathologist reviews under a microscope, and he can see the abnormal plasma cells and count the percentage. Remember, the percentage in order to have myeloma, in addition to the other factors that we discussed, is at least 10%. So FISH, fluorescence InSitu hybridization, can be a little bit intimidating, but simply what it is looking at your plasma cells and looking to see if there's any sort of chromosomal abnormalities. And why is that important? Chromosomal abnormalities can have both prognostic as well as treatment implications for patients. And we know certain patients can have higher risk chromosomal abnormalities, which I have listed here. Translocation 414, 1416, 1420, deletion 17p, or gain of 1q. And those patients can have a more aggressive tumor biology and require tailoring to the therapy to help address the aggressiveness of their disease. So this is a must that must be performed on every bone marrow biopsy in a newly diagnosed multiple myeloma patient. The staging system, as listed here, previously we mentioned the LDH, the beta-2 microglobulin, as well as albumin, which those are blood tests. They look at those 3 factors in addition to the cytogenetic, or the FISH that we discussed before, and group people into 1 of 3 categories. So there's only 3 stages of multiple myeloma, 1, 2, and 3. And you can see the 5-year overall survival based off the stage. But fortunately, over the past 20 years, regardless of which age group an individual falls in, we have made significant progress in the field, and so our patients are living longer. Unfortunately, myeloma is not curable, but we have patients that are living 10, 15, and 20 years. And these series of graphs, not to confuse you, but the red line here represents the overall survival from 2008 to 2010. And if you compare that to the black line, that was the average expected survival back in the late 90s. So regardless of what age group, you can see that patients are doing better and living longer with multiple myeloma. And why are our patients doing better? Well, it's largely because of the new therapies that we have and an explosion in the field and research. So here are all the multiple classes of drugs that we can currently choose from. We have the IMiDs, thalidomide, lenalidomide, pomalidomide, the monoclonal antibodies, elotuzumab, daratumumab, isatuximab, and Blenrep, which is actually an antibody-drug conjugate, the most recently approved drug for multiple myeloma in the relapse setting. The alkylators, the anthracyclines, the proteasome inhibitors, bortezomib, carfilzomib, ixazomib, HDAC inhibitors, panobinostat, and the nuclear export inhibitors, selinexor. I started solely focusing on myeloma in 2013, and maybe a third of these drugs were actually available to give at that time. So how do you decide what treatment to take? It is one of the hardest and most difficult decisions to make, and we get very focused on response, but I just want to point out that response absolutely matters. We want all of our patients to have a great response to chemotherapy in order to live as long and as well as possible. But you have to take other factors. What is the functional status of an individual? Are they really fit? I have extremely fit 70-year-olds, whereas I have frail 50-year-olds. So obviously you'd make different treatment decisions with your physician and your family if you're more frail versus fit. What are potential side effects? That's very important. There are people that have other medical problems, and it could be if certain chemotherapy drugs, for instance, the proteasome inhibitors are notorious for causing neuropathy. If I already have neuropathy from pre-existing diabetes and I take a proteasome inhibitor, would that exacerbate it to the point where I might be more prone to falling? Quality of life is always important regardless of where you're at in your cancer care. So how is this going to affect your day-to-day function? What are your goals, you and your family's goals? Your doctor needs to take these things into account. Cost. Financial toxicity is a real problem in the cancer field. We tend to minimize it, but cost can be a huge stress and burden upon a patient and their family. So really having an honest conversation with that with your provider and asking for drug assistance. Distance to cancer center. So if you live 2 hours away, you may make a different treatment decision. For instance, an all-pill regimen versus somebody who lives 5 minutes away, where solely an IV regimen maybe seem more reasonable. So all of these three things come into effect or come together in order for you to make the best treatment decision for yourself. So patient preference, clinical experience, and research from data. So how do we approach a newly diagnosed patient? And so we still, even in 2020, at that initial visit, we say, is this patient potentially a transplant eligible patient versus ineligible? And a transplant in multiple myeloma is an autologous transplant, so I'm going to fast forward here on the slides, which is completely different than allogeneic. And I think that's very important to point out because when you look at the literature or look on the internet, they seem to be synonymous when they're completely different procedures. Autologous transplant is where you get back your own stem cells after receiving high doses of chemotherapy. So there's none of the side effects that we associate with an allogeneic, such as graft versus host. The mortality rate for an autologous transplant is only 1% per year. Most patients are only in the hospital for a couple of weeks, and a lot of centers do it completely outpatient. Allogeneic transplant is not recommended in myeloma patients unless they're younger and have very aggressive disease, and at UAB we only offer that on a clinical trial. So we always said transplant eligible or ineligible. Auto transplants can be done to patients in their 70s if they're fit. Once we make a decision, we then say initial therapy. So initial therapy is actually induction therapy. The standard, and we'll talk about that briefly, is triplet regimens based off a SWOG study. So 3 drugs are for fit patients, typically what's offered in the upfront therapy. Following initial therapy, you get consolidation if you're transplant eligible with the actual bone marrow transplant. After the transplant, you go on maintenance therapy, which is just one of the 3 drugs. Typically, that's going to be lenalidomide. And you stay on maintenance therapy as long as you're tolerating and responding well. If you're transplant ineligible, meaning that you can't have an autologous transplant, you have to extend typically the chemotherapy. So that initial induction, instead of doing 3 to 4 cycles, you might decide to extend it 8 to 12 cycles, depending on your response and tolerability. After that 8 to 12 cycles of therapy, then you may transition to maintenance therapy, which once again tends to be continuous as long as you're tolerating and responding well. So depth of response, I just wanted to mention this, response rate. So what are we looking at? So to have a response on myeloma means that you have to have at least a 50% reduction in the, we call it a PR, in the circulating protein in the blood or urine. And then a VGPR means a 90% reduction. A complete response means that there's no circulating protein in the blood or urine, and there's less than 5% clonal plasma cells in the bone marrow. A stringent complete response means that there's no protein detected in the blood and urine, and there's no clonal plasma cells detected in the bone marrow. Of late, in the literature, you'll see a lot of discussion about MRD negativity, which means minimal residual disease negativity. And we know patients who are able to reach this milestone tend to have a longer overall survival than those who do not. And this has become a secondary endpoint on several clinical trials. The reason why I mention this is because now the testing for MRD negativity for next generation sequencing is actually commercially available. So you'll see it more and more used in clinical practice. Triplet drugs. So this is the standard of care for induction therapy for patients who are fit with multiple myeloma. The most traditional regimen used is Velcade, Revlimid, and Dex. And the reason for that is there was a randomized study comparing RVD to RD, and what they saw was an 11-month overall survival advantage for those that received the triplet versus the doublet. And so this has become the standard of care. But we always say, since we can't cure myeloma yet, hopefully one day we will soon, can we do better? Can we add a fourth drug to that backbone called, and the one that has had the most data behind it is daratumumab. Daratumumab is a monoclonal antibody against CD38, which is on the cell surface of plasma cells. So you'll see that several studies that I've cited here have used this up front in the transplant eligible as well as ineligible. And the consensus thus far is that you see an overall response benefit as well as a deeper response, as well as a tendency to progression-free survival benefit. However, this data is still maturing, so it'll be interesting over the next year or two to see if the addition of daratumumab up front changes the current landscape. You know, instead of saying triplets for all, maybe it'd be quadruplets for all. But remember, whenever you add an additional drug up front, you may experience more toxicities. So once again, the quality of life versus quantity of life argument becomes very important. So when you look at the number of options up front, I think it's always important to look at consensus based guidelines, and that UAB would participate in the National Comprehensive Cancer Center Network. This is from this year, the most updated version, and you can see here that the recommendations for newly diagnosed patients up front, the preferred regimen category 1, which means the best level of evidence, is bortezomib, lenalidomide, and dexamethasone. There are several other recommendations that can be utilized in other clinical scenarios. You'll also see the quadruplet regimen of dara, lenalidomide, bortezomib, and dex is also considered a reasonable option. This is very similar recommendations for the non-transplant candidates. Well, category 1 includes lenalidomide, bortezomib, and dex. The other triplet that's often used in the clinical practice is daratumumab, lenalidomide, and dex. So a triplet without the bortezomib inhibitor, without the proteasome inhibitor, with the monoclonal antibody and IMiD with the dexamethasone. So initial treatment for patients, the summary is 3 drug combinations are really considered standard of care for induction. Regimens for newly diagnosed patients should include at least 3 of the following: steroids, IMiD, proteasome inhibitor, or a monoclonal antibody. Doublets are appropriate for frail patients. I still use doublets in patients that I've considered for frail, whether it's often Revlimid and Dex, for instance. inclusion of a monoclonal antibody as a fourth drug is a reasonable part of an induction regimen. Data is emerging supporting daratumumab used in the first line. Trying to decide which patients are the most appropriate is a question that we're waiting on the trials to tell us the answer to. And for all newly diagnosed patients, I really encourage them to look at clinical trial options. And that concludes my presentation. Thank you so much. And if you have any questions, I'll be happy to answer them.
Well, thank you very much, Kelly. That was a great presentation. It's hard to get what we're talking about done in 25, 30 minutes, but I'm incredibly grateful to you, Kelly, taking this time on a Saturday to spend with our patients out there in the Southeast. We have about 60 people out there that are watching this right now, and they should be getting a great experience and also can ask some questions. Well, let me preface it right now. This is your Q&A time, so please type your questions in the Q&A box. We have one question from Carol. Well, it's asking is there someone within the IMF that specializes in back injuries that are often a result of MM? I have had very difficult times getting direction about my injuries and expectations from my oncologist and my back specialist. I seem to get passed back and forth with little insight. I would suggest the main thing is to call our info line at 800-452-2873, or you can email them at infoline@myeloma.org. Both of those ways to contact us are available 24/7. It's a message machine on the 800-452-2873. That's 800-452-CURE is the way you can remember that. And then there's immediate, or you can do longer questions that you possibly have to infoline@myeloma.org. Those are great places. Now we have a second question here. Is Kelly on now? Or yeah, Kelly's here. Kelly, my husband had, hey, how are you? I can hear you fine. Can we hear okay? Good.
Great. Sorry.
That's all right. We're questions and answering here. I have a question that I just read. Did you hear the back question?
Yes, I did. I think you give excellent advice.
Oh, okay, good. Well, that makes me feel a little more comfortable. The second question I have here is that my husband has MM. He was diagnosed at 79. He is Caucasian. We have 3 grandchildren in their late 20s and 30s who are mixed race, Caucasian and African Americans. Is there a risk factor for MGUS and or MM increase because they are both direct relatives and African Americans?
I think that's a great question. Not an easy answer, though. So we do know that patients have multiple myeloma, that if they have that there are a first-degree relative, meaning like a dad, a mother, or sister, is 3 times more likely to develop multiple myeloma than someone who is not affected. But I always try to tell patients to kind of put it in perspective. I know this directly affects them, but myeloma is still less common than, for instance, lung, breast, prostate. I guess the next question usually I'm asked is, should my relatives undergo screening because I've been affected by multiple myeloma? And as of yet, there is no data to support universal screening or even screening for family members who have a loved one that's been affected by myeloma. I think we may have the answer to that in the next few years. I know there's been an ongoing study in Iceland to try to answer that question about screening. So in my clinical practice, I tell the patients, if your family members are concerned or have any sort of questions, they should let their primary care doctor know, as any primary care doctor should ask about family cancer history. And if they notice any signs on labs, such as anemia or renal insufficiency, then they definitely should be asked to be screened with the serum protein electrophoresis and the free light chains.
Excellent response. I'm having a few more questions come up here. I want to go back to the back pain. Karen has asked, is back pain a standard and common symptom that is consistent with MM? Can we expand upon that a little bit?
Well, a large percentage of multiple myeloma patients have bone involvement due to the lytic lesions, which can cause like compression fractures as well as pathologic fractures. Definitely, the vertebral spine is one of the more common spots that we see myeloma bone lesions. So it's not uncommon. Now, as far as somebody that specializes specifically in myeloma bone lesions, kind of our practice here is, we get the disease under control, number one. Number two, if you get disease control, then the bone growth can happen. If you have compression fractures causing a lot of pain, we usually use several modalities to help with the pain. We use a combination of often referral to orthospine sometimes. We can also make referrals for vertebroplasty. We can use our SpineNet group here to talk about local therapies such as epidurals to help control pain. And, of course, we can also give pain medicines by mouth to help alleviate the discomfort and improve quality of life. As far as a particular specialist, it's going to be institution to institution. We do have a couple here at UAB who specialize in oncology orthopedics.
Oncology orthopedics. That's fantastic. Thank you for sharing that. I've never heard of that before in 20 years of doing this, or maybe someone said it and I didn't get it. So that was a great explanation. I have another question here from Carrie. They had, or she or he had a BMT, bless you, on 8/31/20, and I'm experiencing numbness in my arms as well as pain that moves between my arms, neck, legs. And has anyone had this side effect? No one seems to know why this is happening. Hospitalization was complicated by 2 episodes of FIB. Chemo drug was melphalan. So I guess in short there, did you catch that question?
Yes, I did. So I would say the hospitalization question about AFib is not an uncommon thing that we see. AFib is just a heart arrhythmia that is not uncommon when our bodies undergo stress. So we probably see that in a small percentage of our patients for sure, so it's not uncommon. Now, the side effect, it sounds like potentially neuropathy that they're experiencing in their arms and legs, maybe not necessarily neck. We do see this as a complication. Often, it happens prior to transplant, given whatever induction regimen they received, and then post-transplant, it can be a little bit exacerbated. I guess the neck part has me the most concerned, as that's a little atypical for peripheral neuropathy. Whenever somebody complains of neck pain, I usually do some sort of neck imaging. But as far as the arms and legs, working with either Lyrica or gabapentin to help control the peripheral neuropathy, which should improve with time as you get further from the induction as well as the transplant.
Good. So a good comment there is give it a little bit of time, relax, and let some of the treatments take care of what might be able to handle some of your issues. Great response. I have a comment, or let's see, a question from Tina. She has spoken about the screening in Iceland under the Black Swan program at the IMF's official research arm. And she's wondering if there's any study with participants of African ancestry here in Alabama at your institution.
So we do have an image study where it's looking at kind of differences based off race as well as sex and geography of where patients lived over the course of their lifetime, but it's more an epidemiology kind of environmental study that's led by our investigator here, Beth Brown. It's not a treatment-based study, though. It is more trying to understand the differences that we see amongst the general population in myeloma, because it's a very heterogeneous disease, and we just put it all under the label myeloma, but we see differences amongst individuals for sure in their disease biology and how it behaves.
Sure. Dr. Costa, Luciano Costa has joined us. He'll be our next speaker. Dr. Costa, do you have anything you'd like to add to that?
No, I very much agree with Dr. Godby. I think there's quite a bit of effort to understand the peculiarities about the myeloma incidence in response to therapy among different racial groups. There is also, I would say, I would say, cultural and historical momentum on being more intentional and deliberate in ensure that racial minorities are properly represented in clinical trials, which has been a silent tragedy in the myeloma field.
The IMF is spending a lot of time on this, Dr. Costa, and you might know our Chief Scientific Officer, Dr. McHale. And we'll be doing some presentations with him on November, what's the second weekend? November 14th? November 14th or 12th, I can't remember, but you do want to join for that. So thank you, Dr. Costa. Let's see, another question just popped up. And this is a tough one. I've had this happen before in these workshops. What is being done to educate family practice / general practice doctors so that multiple myeloma can be diagnosed earlier? What is your guys' comments on that? Luciano, can you go first?
Certainly, I'm certainly happy to mention. I think, yeah, we tend to all live in, we're all very busy. We tend to live in bubbles and very busy taking care of the patients who have been diagnosed and are ill or need direct intervention. So sometimes a very important initiative doesn't get high priority. The physicians that are on the front diagnosing those patients, they have a very difficult challenge because many of the manifestations of myeloma are very common, including back pain or anemia or renal dysfunction. Those are manifestations of several other conditions that are far, far more frequent than multiple myeloma. So it's a very, very difficult task. The way to improve upon that is essentially, improving education about myeloma to internal medicine physicians, to orthopedic physicians, to nephrologists, and that is often, done in the in the academic setting, but I'm not so sure that can reach out the community. I think it will be very important for organizations like the IMF to spearhead that kind of education. Another thing that I think is very important, as we all know, there's no screening for multiple myeloma. There's no screening strategy for multiple myeloma. However, I want to mention here the PROMISE study, which is a study led out of Dana-Farber by Dr. I'm blanking on her name now, but is led out of the Dana-Farber Cancer Institute that essentially is screening patients considered at risk for multiple myeloma. And that is anybody of African-American descendants or anybody with a first-degree relative with multiple myeloma. So the idea is maybe if we can identify more patients on the preclinical stage, we might develop strategies for early diagnosis and see if they would affect the outcome. So anybody who is interested should Google the PROMISE study from Dana-Farber and encourage family members to join that initiative. It's very simple.
Oh, that's great news. It's a complicated effort for us, but we are all, as many teams across the country, working on this, and I think that that's important to understand. There's a lot of research in them are hills and adversity, and I think that that's important. So, excellent response. Well, that was an excellent. Let's see. Can I take one more question? Okay, well, we're going to take one more question. I am post-ASCT, VGPR status. I was on maintenance with 10 milligrams Revlimid, which caused the WBC and ANC to drop. My Rev was reduced to 5 milligrams. Can this lower dosage be effective in combating myeloma? Either one of you?
Dr. Godby?
Can you still hear me?
Yes.
Yeah.
Sorry. Yeah, so I think that nobody knows the exact dose that you need in order for an IMiD to truly be effective. So with that being said, in my clinical practice all the time, I have people that are unable to tolerate the 10 milligram dose after transplant daily. And we often, because of the leukopenia or the neutropenia, and it's not uncommon that we give them 1 week off a month or dose reduced to 5 milligrams. And the best dose is a dose that you can tolerate safely that also helps control your disease.
Sure. That's a good point there, because all treatments are individualized to the patient. And that's something that's really unique to myeloma, because everyone, as you all know out there, this is the bad part about it, all myelomas are different. But now they have a bailiwick or an amount of treatments out there that they haven't had in the past. So that's enough questions for this segment. I'd like to get to our next segment here. Again, we're the International Myeloma Foundation. We can be reached at myeloma.org or 800-452-2873. The next talk, relapse therapy, emerging therapies, and clinical trials with Luciano Costa.
Hi, my name is Luciano Costa. I'm a professor of medicine at the University of Alabama at Birmingham, where I chair the Multiple Myeloma Working Group. And today I'm going to talk to you about management of relapsed multiple myeloma, including some emerging new therapies. So one question that often comes up is when to change therapy on a patient. We certainly should do so if there is development of new signs and symptoms of disease. That's a clear sign that the prior therapy is no longer working, or that period of observation without therapy has ended and the patient needs new treatment. We also oftentimes change therapy because we see what we call biochemical progression, which the patient is not symptomatic yet, is not having worsening pain or worsening anemia or worsening of the calcium, but the M spike is increasing in the blood and the urine, and a clear sign that the prior therapy, again, is no longer working. Sometimes we change therapy because even though the prior therapy has not stopped working yet, the toxicity becomes difficult to manage. Regardless of what the reason is, the goals of treatment should be the same, which is regain control of the myeloma for as long as possible, alleviate the current symptoms, prevent myeloma serious event, particularly severe anemia needing transfusion, renal failure, fractures, etc. And ultimately, by getting a better disease control to prolong the patient's survival. So how do we choose a regimen for a patient? So there's not such a thing as a one size fits all. We always have to balance many aspects on that patient to choose a therapy. The pillars of therapy tends to be, immunomodulatory agents such as Revlimid, Pomalyst, or Thalidomide, and or proteasome inhibitors such as Velcade, Kyprolis, or Ninlaro. Every time that is possible, we should consider clinical trial. A clinical trial option is always at least as good as the standard available therapy and should always be considered. We take in consideration the disease characteristics, how quickly the relapse is happening, how aggressive the relapse is happening, how debilitating the symptoms are, prior therapies. In general, when the patient, when the disease is no longer responding to a drug in a certain class, it's unlikely to respond to another drug on that same class that is not of higher potency. So we use those as kind of general guidance on choosing a regimen. We take into consideration toxicity from prior regimens. For example, if a patient has significant nerve damage from a prior therapy, we're going to try to avoid drugs that can cause further nerve damage and so on. Coexistent diseases, things that are very common, for example, heart disease. Some drugs are associated with increase in cardiovascular complications, and we tend to avoid those in patients with cardiac disease and so on. the frailty of the patient, so how functional, how alert, and how mobile the patient is, means a lot. Of course, we tend to be more intense and more ambitious on our therapies on patients who are not frail, and tend to be more conservative on patients who are more frail. Last, convenience. Convenience is important. In general, oral drugs are preferred over IV drugs, and drugs that have a not so frequent schedule of administration that requires multiple trips to the doctor's office or the infusion suite are preferred. However, most of us will not trade that for efficacy. It's very important to keep in mind what we're up against, which is myeloma, which can be a serious disease. And I'm okay choosing for the most convenient regimen, as long as that is not a significant compromise in efficacy. And goes without saying that by far the most important and at the end of the day, the only thing that matters is the patient's preference. So I use all those reasons, all those factors to make a recommendation and to guide the patient, but ultimately is the patient preference that's going to dictate the next therapy. So let me review with you some of the most recent data that help us on that guidance. So one study I want to share with you is a study called ASPAR. That's a study that compares Revlimid and dexamethasone, which is a very active regimen in patients with relapsed myeloma, versus carfilzomib or Kyprolis plus lenalidomide and dexamethasone. So that was one of the first few studies that compare 3 drug combinations versus a 2 drug combination in the relapse setting. And that showed clearly that a combination of Kyprolis, Revlimid, dexamethasone has higher rate of responses, and the patients tend to go on for longer without progression of the disease or without death. And we call that progression-free survival. So you're going to see several of those curves throughout the presentation, and the curve that is on top is the winner. So in this group, in this case, the Kyprolis with Revlimid and dexamethasone greatly outperform just the Revlimid and dexamethasone alone. Another trial, as many of you know, Kyprolis is a proteasome inhibitor, just very much like Velcade, which begs the question, which one of those drugs is best? And that question was asked for patients with 1 to 3 prior therapies, and now with relapsed myeloma. Patients were randomized to receive Kyprolis, dexamethasone versus Velcade and dexamethasone. And again, we see clear superiority of the Kyprolis containing regimen over the Velcade containing regimen. The Kyprolis is certainly a great drug, but it's given intravenously, either with 6 doses a month or 3 doses a month, which makes it a little bit inconvenient. One other study that has that is important, that studied the only orally available proteasome inhibitor. That's the ixazomib or Nilaro, and followed the same model that we saw on ASPAR. So they compare against Revlimid and dexamethasone versus Revlimid, dexamethasone, and ixazomib or Nilaro. And again, you see superiority of Nilaro, although not to the same magnitude that we saw with Kyprolis, but it's certainly a great option because it's an oral regimen. So it's oftentimes we take that option for patients where frequency of visits to the doctor is an important factor. More recently, we had, I think, one of the greatest breakthrough of myeloma therapy in recent years, that is the advent of monoclonal antibodies. Monoclonal antibodies are antibody proteins, so immune proteins that have been engineered to tag a specific target on the cancer cell, so the cancer cell is further, destroyed by the immune system. The first monoclonal antibody is elotuzumab. The trade name is implicit, and that targets a protein called SLAMF7 or CS1. Again, the comparison here was Revlimid, dexamethasone versus elotuzumab, Revlimid, and dexamethasone. And again, we see higher rate of responses and higher proportion of patients over time who are alive and well and free of progression. Again, the same topic of 3 drugs being better than 2. Not long after, we had the introduction of daratumumab, which is also a monoclonal antibody with different mechanisms of actions, but here it targets something different. It targets something called CD38, which is present in every single myeloma cell, every single plasma cell. Again, the same comparison, Revlimid, dexamethasone versus Revlimid, dexamethasone, and daratumumab. Here we see responses in 93% of the patients. So that's a high rate of response that until not so long ago, we could only see in newly diagnosed patients. And now we're seeing patients who have disease that is relapsed or refractory. Not only patients were more likely to respond, but also those responses last longer. And here at the time of this analysis, after 1.5 years of therapy, the 3/4 of patients were still well and free of progression. Daratumumab can be combined also with Velcade. So this is the combination of Velcade, dexamethasone versus daratumumab, Velcade, and dexamethasone. Again, very high rate of response and longer progression-free survival. Very recently, we had those very important trials called Candor and IKEMA. The idea here is we saw the developments with Kyprolis as a newer proteasome inhibitor, and we saw the developments of monoclonal antibody in relapsed myeloma. But why not combine the best of both worlds? Why not combine your best proteasome inhibitor with a potent monoclonal antibody? And this was this trial did. It compared Kyprolis and dexamethasone versus Kyprolis, dexamethasone, and daratumumab. The response rates here was greater than 90% in patients 1 to 3 prior lines of therapy. And the combination of the 3 agents greatly outperformed the Kyprolis and dexamethasone alone, again, creating another triad, another triple therapy that is particularly relevant in this day and age where most patients will have received Velcade, will have received Revlimid as part of the initial therapy. So that becomes a very relevant regimen. We talk a lot about daratumumab, but there's a new anti-CD38 monoclonal antibody called isatuximab. It's also intravenously administered. And isatuximab has been combined with Pomalyst, which is a immunomodulatory agent, which is an evolution of Revlimid, if you will. On this trial called Icaria, the combination of the 3 drugs was far superior than Pomalyst and dexamethasone alone. And this trial is very important because the majority of patients here were had disease that was refractory to Revlimid. So a disease that had no longer responding to Revlimid, and despite that, they still did very well with a Pomalyst containing combination, in this case, isatuximab, Pom-dex. More recently, as of a few months ago, we got to know the results of the IKEMA study, very similar to Candor that we saw before, again, combining a CD38 monoclonal antibody with Kyprolis and dexamethasone. But here the antibody is isatuximab as opposed to daratumumab, very similar results, again, 3 drugs better than 2. So the theme, if I were to summarize for relapsed refractory myeloma is every time it's possible, combine 3 drugs as opposed to 2. Try to use a drug that has not been utilized before, or try to use a class of drugs that has not been explored before. I think in this day and age, there's very little reason to recycle a drug, to repeat a regimen that is already used early on. We should think more about recycling classes. So if you use a first generation proteasome inhibitor, now we should go to a second generation proteasome inhibitor. If you use a first generation immunomodulatory agent, now we should go to a second generation and so forth. Let's talk a little bit on the few minutes that we have left about emerging therapies. We talk about immunomodulatory agents, proteasome inhibitors, and monoclonal antibodies. Now we're going to talk about other types of therapies. And one I want to talk about is venetoclax. Venetoclax is an oral drug that is approved to treat other blood cancers, including some leukemias and lymphomas. And the way venetoclax does, it binds to this protein called BCL2. And BCL2 is anti-apoptotic drug. So it's a drug that keeps the cell from going its natural death path. So it makes the cancer cell survive despite all the attempts we have at killing it. So by using venetoclax, we are potentiating that pro-apoptotic pathway. We're facilitating the cancer cell to die. That's a very intriguing idea. And when this was tested in multiple myeloma, it was very early noticed that patients with something called translocation 11;14, which is one of the most common chromosome abnormalities in multiple myeloma, is seen in about 1 in every 5 myeloma patients. And for the most part, the disease is not very different than other myeloma patients, but those diseases are exquisitely sensitive to venetoclax. As you see here, patients were heavily pretreated. Venetoclax and dexamethasone by itself had a response rate of 40%. So we're going to see in the years to come this drug being more explored into the subset of patients. Very recently, we had the approval of selinexor. Selinexor is an exportin inhibitor, and exportin is a protein in the nucleus of the cells, and including the cancer cell, that does a lot of work pumping out of the nucleus several things that are necessary for gene regulation. And when we block that exportin, we keep in the nucleus some things that are expected to be there for the cell to run its natural cycle, including dying. Selinexor is an oral agent, so in that regard it's convenient. Can be given twice a week or once a week. And when used in a population that was heavily pretreated, with all patients have had prior proteasome inhibitor immunomodulatory agents and daratumumab, about a quarter of the patients had a response. It has some intriguing side effects, including low platelets, a lot of nausea, and some weight loss. So the supportive care becomes very important, even though it's an oral agent. A lot of the excitement in the past couple of years, however, resides with immunotherapy, particularly with CAR T cell therapy. And here I highlight all the targets that are being explored or are soon to be explored, and particularly BCMA, that stands for B cell maturation agent. And that's where most of the data I'm going to share with you. CAR T cell works by taking T cells, which are a normal part of our immune system. There are cells specialized in doing direct cell-to-cell kill, and reprogram those cells using a genetically modified receptor. So those cells now recognize BCMA on the surface of the myeloma cell, directly engage and kill the myeloma cell. The process can be somewhat complicated, as I'm showing here on the case of BB2121, which is the CAR T cell that is further along in development and the one that is most likely to be approved first by the FDA. The patients first undergo leukapheresis, which is the collection of these lymphocytes from the blood. Those cells are shipped out to the laboratory that does the manufacturing. So use usually a viral vector to transfect into those cells that man-made receptor that will teach the T cell to recognize cancer. The patients undergo some chemotherapy, which is some light chemotherapy just to prepare the immune system to receive those CAR T cells, and the CAR T cells are infused. And after that, the patient undergoes supportive care and observation. It's not a continuous therapy, it's a one-time treatment. On the case of KarMMa-2 with BB2121, overall, the 73% of the patients responded. The higher dose, the responses were 82%. That is incredibly high, keeping consideration that all those patients had received multiple prior therapies, including daratumumab, carfilzomib, Revlimid, Velcade, and Pomalyst, the vast majority of the patients. Those responses can be durable. In patients who had a complete response, which is about over a quarter of the patients, the median progression-free survival is now over 20 months. So very promising for those patients. We have a lot more experience with JCAR-H125, which is a very similar CAR T cell. We first saw those results updated earlier this year at ASCO. And again, we're seeing over 90% of response, about a third of the patients having a complete response, despite being heavily pretreated. The most common toxicity, or the signature toxicity of those therapies, is something called cytokine release syndrome, which is essentially a storm of inflammation that happens as part of that engagement of the immune system. Nowadays, we know very well how to control and how to prevent and how to manage, but it's nevertheless something that can be scary, but it requires, in a hospital-based management. Another CAR T cell is called JNJ-4528, produced by Janssen. This really is an evolution of the first product that we heard about in myeloma. There was a Chinese manufacturer called Legend. They partnered with Janssen, and this is the first results in the United States of 29 patients with about 100% response rate. Keep in mind, those are preliminary results on a small sample size. So I'd like to discuss the good, the bad, and the ugly regarding CAR T cell. It's a very active therapy. Near all patients respond. It's a one-time treatment. Responses are fast and is active in even very refractory disease. Patients often enjoy a treatment holiday where they go on for months without needing any more therapy. And even though we sometimes make comparisons with transplant because we collect the cell, process the cells, infuse the cells, you don't have those side effects of hair loss, digestive side effects, and so forth. It has some caveats. It takes some time to manufacture those cells, a few weeks. The low blood counts can persist sometimes for weeks and a few months. Patients tend to become low in immunoglobulins, predisposing to some infections, and need hospitalization. And we still don't know if some of those patients might have a permanent response like we see in other diseases treated with CAR T cell. And then you have the more scary thing, like something called ICANS, with some sort of toxicity to the brain that is often, fortunately rare and often transient, but can be pretty scary. The cytokine release syndrome that I described. And I think what is the ugliest part of CAR T cell is the access. It's still a therapy for very few, available only in clinical trials. And when approved, is likely to have a steep price tag and be only available in some selected centers. There are other ways to engage the T cells other than taking them out of the body and manipulating their genes to fight cancer. You can use what's called a bispecific antibody that forms a bridge between the cancer and the T cells and cause the T cells to engage and kill the cancer. I had the privilege of presenting recently results of one of those bispecific antibodies in development called CC93269. And at the optimal dose, we're seeing responses in close to 90% of the patients, including deep and durable responses. And these are a very similar population that we see with CAR T cells, so patients heavily pretreated. Last but not least, another way to leverage from immunotherapy, particularly BCMA, is using what's called antibody-drug conjugate. Here you have a monoclonal antibody that, like daratumumab, for example, that binds to the cancer cell, but instead of depending on the immune system to engage and then destroy the cancer cell, this antibody carries with it a payload, a chemotherapy drug that gets delivered within the cancer cell, causing high concentrations of the chemotherapy in the plasma cells. So it's very clever approach to immunotherapy. This drug is now approved. It's called belantamab mafodotin, or Belamaf. The trade name is Benraf. In patients who have 3 or more prior lines of therapy, had received the monoclonal antibody, the PI, and the IMiD, the response rates were about 30%. And the signature toxicity for this drug is, however, keratopathy, which is damage to the cornea of the eye, which oftentimes leads to dose interruptions or dose reduction, and can be quite cumbersome for some patients, and requires that the patients will have a dedicated eye exam before each of the doses. So it remains to be seen how well accepted this treatment is going to be among patients and among oncologists. And with that, I want to leave you with this table, just for your reference, that gives us the highlights of the 3 different approaches are taking on targeting BCMA for myeloma therapy. Again, I'd like to thank you for attending and for inviting me for this occasion. Thank you very much.
Well, thank you, Dr. Costa. I really appreciate everything you just went through. Before we go on to questions and answers, I wanted to thank Doris Morgan, Carol Cunningham, Thomas Good, Tiffany Williams, and Jim Mahoney for what they do. They run support groups in the Southeast, and I really think that if you're in those areas, you need to be part of a support group. So, Dr. Costa, that was a long talk. You went into one thing, and a question popped up right away. Can you take Dex after relapse? Can you take Dex after relapse?
So the answer is yes. I mean, dexamethasone is one drug that is almost like a fixture on every single myeloma regimen that there is. And so in some occasions, it's even a therapy on itself. Sometimes we employ dexamethasone alone without any other agent. Quite honestly, I think dexamethasone is something that we take too much liberty with, because for most other cancer agents, once that agent is no longer working, we tend to drop it and substitute it with something else. But we have the habit of keeping dexamethasone in just every line of therapy. And as many in the group know, that drug is now without toxicities, sleep disturbance, weight gain, hypertension, diabetes, and so forth. So in my approach in general is when employing a regimen in the relapse setting, I use dexamethasone, but then at the beginning and once the patient responds, I greatly reduce the dose or discontinue dexamethasone altogether.
Excellent. Now, when all patients who had, this is another question, when will patients who have had BCMA already be allowed into clinical trials? It seems like it's an exclusion of some sort, so BCMA inclusion in clinical trials. What is that?
So that's a great question and very, very, very timely. There have several different BCMA targeting strategies that have been developed simultaneously: CAR T-cell, antibody-drug conjugate, and bispecifics. So at first, all those trials excluded patients who had other BCMA-based therapies. However, that is changing rapidly. Now there's a growing interest in learning how patients who had a prior BCMA target therapy respond to another BCMA target therapy. So many of those trials, the newer trials, are enrolling those patients and enrolling a cohort or a subset of patients who had other BCMA target therapy. So in our site, we have a CAR T-cell study that is enrolling patients who had other prior BCMA therapy. We are soon going to have, or we have bispecific antibodies that have had cohorts that have prior BCMA-based therapy. So don't accept that as a permanent fact. This is changing rapidly. Just look around, reach out to the different cancer centers, explain your situation, see if there's a trial for you.
Great response, doctor. Folks, let's give them a round of applause as you can at your house. I appreciate both you doctors being here. Apparently you're on rounds today, so to take time to help us out here as patients, I'm really, really, really sincerely grateful. Have a great day, doctors. We'll talk soon. I'll get you the link for all this so you have it for your patients. Thanks, Dr. Costa and Gabi.
And we appreciate the opportunity, and we appreciate all that you do for the patients. Thank you so much.
Oh, it's our pleasure. Likewise, it's our pleasure. Bye-bye. All right, now the International Myeloma Foundation has been doing what we do for 30 years. I mentioned the support group leaders earlier, and I just really want you to know that it's unconditional love and unconditional education in our support groups. When I started 20 years ago, we had 5 support groups to handle the whole entire country. Now we have over 150 support groups that we work with to help your education process and your whole involvement with multiple myeloma to be better, because it has to be. You have to treat yourself better now. They are doing that. A lot less side effects than there used to be, and a lot more opportunities for successful treatment. With that being said, I'd like to introduce someone that I have worked with for a few years. She has been incredibly helpful throughout the years, not only participating in my regional community workshops, but helping me through some of my questions so that I'm a better facilitator when I go to the meetings. This topic is called Living Well with Multiple Myeloma, or Living Well with Myeloma. And this is put on by our Nurse Leadership Board presenter, Beth Feynman. She's at the Cleveland Clinic. I might make a mistake here. Taussig Cancer Institute. And I would like her to take it away with her presentation right now. Take it away, Beth.
Hello, everybody. My name is Beth Feynman. I'm a nurse practitioner from the Cleveland Clinic in Cleveland, Ohio. And I'm so thrilled to be presenting today on the topic of multiple myeloma and symptoms. I finished my PhD at Case Western Reserve in Cleveland Clinic, Case Western Reserve in Cleveland, and the focus was symptoms in myeloma. And I think you'll find some helpful information in this slide deck. Today it's titled Be the Commander of Your Galactic Journey, Constellation of Symptoms, kind of going with the Star Wars theme here. I think it's important to understand that things you feel symptoms can be from either the myeloma itself or from treatments of the myeloma. And both of these can cause a constellation of symptoms and contribute to how you feel. So for example, at diagnosis or throughout your myeloma journey, the myeloma cells in excess might cause certain symptoms such as high blood calcium levels, high creatinine levels, those are your kidney levels, anemia or bone pain. The cells can also create chemicals that make you feel tired, make you at risk of infection or other symptoms. Sometimes our treatments for the myeloma cells to kill the cells can cause symptoms too, such as low blood counts. We call that myelosuppression. Numbness and tingling in your fingers or feet are called peripheral neuropathy. Diarrhea, more fatigue, increased risk of blood clots, etc. And I'll be discussing these throughout today. But it's nice to know that we have treatments for some of these. And I think the most important takeaway from the idea of these symptoms is that you tell your doctor and your healthcare team what you're experiencing and make a journal so that they know how they can help you. Now, the next 3 slides are just going to be nice to know and kind of take them with you. Remember, these are all downloadable for you. These are common side effects of myeloma drugs. I'll just walk you through a couple of these on this slide, for example. So this first 3 are called the MIDs, or immunomodulatory drugs. Those are pills, thalidomide, lenalidomide, and pomalidomide. Those are very effective at killing myeloma cells in the bone marrow, and we typically give them with other medications. As you can see on this table, these drugs cause an increased risk of blood clots. They can lower your blood counts and cause other side effects such as kidneys, rashes, or fatigue. So it's important to talk with your doctor and healthcare team if you're experiencing any of these side effects. Now, the next one in the blue, this category is proteasome inhibitors, or MIBs, and bortezomib, carfilzomib, and ixazomib are in this class of drugs. What's nice is that we have not always overlapping side effects. So bortezomib, for example, is commonly given in newly diagnosed myeloma with lenalidomide, for example. And so when we give those drugs together, you might not have the same side effect, but be aware of peripheral neuropathy, low blood platelets, that's thrombocytopenia, and some stomach symptoms such as nausea, vomiting, or diarrhea. And vomiting is not a common side effect of most myeloma therapies. So if you're experiencing this, let your healthcare team know. On this next slide, you can see other drug classes. And boy, when I started managing myeloma in the 1990s, we only had not even a handful of options. We had steroids and some other older drugs, but really and truly, all of these drugs came about between 2000 and current 2020. In the light green, you have these monoclonal antibodies. Those are daratumumab, elotuzumab, and the newly FDA-approved isatuximab. That was just FDA-approved in March. The important thing about monoclonal antibodies is that I see a lot of fatigue and weakness as the biggest concerns, but that's usually early on in the treatment. And of course, we give pre-medications such as Benadryl so that you don't have an infusion reaction, and so that can contribute to sleepiness and tiredness as well. But for these drugs, it's really the infusion reaction, maybe some increased risk of infection with this myelosuppression or low blood counts. Blenrep or belantamab mafodotin was just FDA approved. It's also an antibody drug conjugate, can cause some low blood counts and infusion reaction, but the big deal with this drug is that we need to watch out for what's called keratopathy or eye problems. And so you'll learn all about that if your doctor thinks that's right for you. Feradak is a pill that's taken usually in combination with bortezomib, but there are ongoing studies that show the benefit of that medication. And then Xpovio, that is selinexor, that was FDA approved in July of 2019, and that drug can lead to low blood platelet or thrombocytopenia, some low blood sodium levels. So your doctor and nurses and healthcare team will work real closely with you if you're on this medication to protect your side effects of stomach, nausea, weight loss, and low blood counts. This last slide lists a couple of older drugs such as anthracyclines and alkylating agents. Those classes of drugs can be mixed and matched with any of the other medicines that I just mentioned. The anthracycline doxorubicin was the most important medicine from the 1980s to 2000. We had just doxorubicin. We still give it in some we call salvage regimens when people have had a lot of treatment. But this medicine can lead to infusion reactions and low blood counts, and so your doctors and nurses will protect you against those. And then alkylating agents, melphalan. Many of you have heard of that when you've gotten a bone marrow transplant or stem cell transplant. We still use that in pill form. We can give it as an IV before transplant. And then cyclophosphamide. We use a lot of that at the Cleveland Clinic. It's great for people that their kidneys might not be 100%, and it's very well tolerated, although despite all these side effects, we give it for a lot of different conditions. Now, you might have noticed that I didn't mention steroids on any of those treatment slides, but you're also probably very well aware that dexamethasone, which is a very hot topic in 2020 with COVID, dexamethasone is a treatment for many disorders and conditions, including multiple myeloma. There have been numerous studies that show that adding dexamethasone or prednisone to any of our chemotherapy regimens or novel treatment regimens make them work better. And let's be honest, sometimes a low dose of steroids can give you a little pick-me-up. It can make you more effective at doing your housework after the treatment, and it lasts for about 48 hours. But unfortunately for many, steroid side effects can be very, very hard to manage. Irritability, mood swings, insomnia. It causes you have an increased risk of infections, cataracts, facial flushing. Those of you that have high blood sugar levels or diabetes can have very, very challenging time managing your blood sugars. And of course, it causes some swelling and water retention. Managing steroids, a lot of it we have to have the discussion. If you're having such problems with the steroids, it's okay to reduce the dose in many cases. We only need a little bit of steroids for many people to help marry well with the treatment that you're on and help the treatment work. It's important to try to take it consistency. Most people take it once a week with oral pills, or you'll get it in the IV when you're getting your chemotherapy treatments. Some people like to take it right before bed because they find they can sleep through the initial side effects and they don't have as many lingering days of problems. Take it with food, and if you're having stomach discomfort, talk to your healthcare provider about over-the-counter or prescription medications. Patients that have steroids are often at an increased risk of shingles and thrush, so therefore you might be prescribed some acyclovir or other medications to protect you. It's important to remember that steroids help kill myeloma cells, as I mentioned before, so please don't stop or adjust the doses without discussing with your healthcare team. This next slide highlights some other very important side effects that you might experience from the myeloma or the treatment itself: fatigue, depression, and anxiety. When you're in the room with your healthcare provider, and it might be a short period of time, sometimes you don't want to bring up that you're tired or depressed or anxious, and you just have a shorter bit of time, so maybe you are more concerned about learning about your disease and how your treatment's going. But all of the above can affect your quality of life and your relationships. There have been numerous studies that show that exercise such as light walking, yoga, proper rest, hydration can really help some of these side effects. Focused meditation, working with support groups such as the IMF has so many of them, and you're here today, and so that lets us know that you're interested in support groups. But prayer and meditation are also very important. Even my Fitbit that I wear every day has 2 minutes of deep breathing exercises. So sometimes if I'm feeling overwhelmed at work or at home, I just close my eyes for a few minutes, taking some deep breaths, and listen to some music. Massage and aromatherapy can help, as well as some supplements such as ginseng. I like to recommend American ginseng. It has some studies in the palliative care literature, if you're interested in it, that can help give you a little bit of a pick-me-up sometimes and kind of help some of the anxiety. If it's from anemia, that fatigue, sometimes a blood transfusion can help. And the little purple bar on the bottom was from a study that I conducted at Cleveland Clinic. The study was looking at symptoms in myeloma, and we were so worried about not addressing people's symptoms. And I gave them an iPad and they could answer the questions. But what was the most important thing? That 70% of people mentioned that they had moderate to severe fatigue, but only 20% actually mentioned that it was bothersome. It was almost like it was an accepted part of the treatment. So talk about side effects and concerns with your doctor, of course. Infection. We're all about infection these days with the current COVID pandemic. I think myeloma patients do an excellent job at hand washing, looking and reporting for fevers over 100 degrees Fahrenheit, or 38 degrees Celsius, shortness of breath, chills, and knowing what to do, who to call. So if you're not sure what to do at 5:30 p.m. on a Thursday, find out the on-call doctor's number and have that handy. We can give white cell growth factors to help stimulate the healthy white cells grow back if, based on certain regimens, that's indicated. Immunizations are great. Everybody should receive the seasonal inactivated influenza vaccine unless you have a egg allergy or have had Guillain-Barré before or a bad reaction. And of course, Pneumovax, you get 2 steps every 5 years. So the Centers for Disease Control recommend the polyvalent 13 vaccine, and then 8 weeks later, the standard 23-valent vaccine. Discuss these with your doctor if they're right for you, and just kind of keep a mental note if you're due for them or not, or ask. New research does show, as of 2017, and we have this updated as well, that for patients receiving myeloma treatment and newly diagnosed, levofloxacin, which is an antibiotic pill, can lessen your chance of early death. And so a lot of physicians are now recommending this at the beginning of initial therapy. But again, good hand washing and physical, not social distancing. Dr. Dre likes to say physical distancing, stay apart, but still remain social. Now, blood clots. This is a huge problem for myeloma patients in many cases. Deep vein thrombosis, or DVT, occurs when you have a blood clot in a deep vein. Usually starts at the leg, and then we worry as it jumps over the knee space, that can catapult into the lung and cause a pulmonary embolism, which is a life-threatening situation. There are very well-known risk factors. The myeloma itself, when it's active, can cause an increased chance of blood clots. And then there's a personal and family history. Maybe you had a blood clot when you're flying to China 20 years ago and didn't think much of it, or after a long trip. Let your doctor or your healthcare provider know if you have a personal or a family history of blood clots. If you're smoking, obese, and just not moving around, that makes your platelets more sticky and more risk for blood clots. People that are undergoing medications such as surgery or immobile, we worry about those patients as well. Anybody in the hospital definitely needs to have prevention against blood clots. Some of the symptoms would be swelling in one leg or the other, tightness in that extremity, blood clot in the lungs, shortness of breath, anxiety, rapid heart rate. These are all things to look for and report immediately. I've had a couple of people with blood clots in their lung complain of sharp pains in their back and with the shortness of breath. So everybody who's on many different medications should be on a baby aspirin or a blood thinner. Talk with your healthcare provider, ask them what your risk is, and make sure you stop smoking if you're smoking. Make sure you're active and moving around, and make sure to take travel precautions. Sometimes I tell people, maybe get up and walk around, trace the alphabet with your legs if you're on a long car ride, but these are very serious conditions to report. Now, this next slide has a lot of words on it, and I won't go over every single list of words here, but GI or gastrointestinal symptoms do occur in patients with myeloma more frequently with some of the newer drugs, unfortunately. Carfilzomib, I think, in some rare cases, cause a lot of nausea when it's given with a drug like cyclophosphamide, which is that Cytoxan, an older drug. Selinexor or Expovio, that can cause a lot of weight loss, lack of appetite and stomach. But again, we have treatments to help keep you and adhere to the treatment that's recommended that you need to treat the myeloma. The list to the left of diarrhea potential causes, it's funny because magnesium is in a lot of vitamins and in megadoses sometimes, and that can cause diarrhea. I've had people come to me say, oh, I have such diarrhea, I don't know what it's from. And then I look at their medications and I see lots of magnesium in some of the supplements. So make sure the patients know what they're taking. Milk thistle, aloe, ginseng, these can all cause some GI symptoms. If it's not presumed to be infectious, such as foul smelling or an acute change from maybe something you ate, antidiarrheal medication over the counter is generally okay, but talk with your healthcare team. I've done research with long-term lenalidomide in my PhD studies, and some patients can get diarrhea from 17 to 24 months after starting Revlimid for their maintenance after transplant. And it might not always be a bad thing, but for those people, I tend to recommend Welchol or cholestyramine. It's a powder, and it tends to be a lot better for a functional Revlimid-induced diarrhea or medication-induced. Constipation from opioids, high blood calcium levels, and some calcium supplements. So definitely increasing fiber, Metamucil with lots of water, or some stool softeners if need be. And then nausea could be from any of our medications, either mild, moderate, or severe. And definitely we don't want you to have severe nausea. If it's mild, then maybe adding some pre-medication before your chemo if we think it's from the chemo. Avoiding fatty, fried, spicy, or too overly sweet foods is important. And then sometimes we give just acid reducers, which are over the counter, which can help with that. But of course, talk with your healthcare provider about any of these concerns. Understanding changes to kidney function is very, very important. Many patients with myeloma will have damaged their kidneys at diagnosis or throughout their lifespan. Active myeloma, high blood calcium, diabetes, high blood pressure. There are numerous reasons why people would have impaired kidney function. Again, with age, you have this functional decline in your kidney function anyhow. The best way for you as a patient to protect yourself and prevent kidney damage is by drinking. Drink lots of fluid, anything that spills. If you're on water pills for blood pressure or heart condition, just make sure you work with your doctor so you don't get dehydrated, especially if you're working outside in the yard when it's warm out. Sometimes you forget to drink. Medications that can damage the kidneys include ibuprofen, or we call non-steroidal anti-inflammatories, and IV contrast dyes. If you have belly pain, you go to the ER, they might give you dye in the vein. Those could be very hard on the kidney. So let your healthcare team know you have myeloma and that you should stay very well hydrated. Treating the myeloma if the myeloma is the cause, or the high blood calcium if the calcium is the cause, is super important. And in many cases, if we find this early, we can reverse impaired kidney function. Again, many patients will experience this at some point during diagnosis. It's important to know the medicines to avoid. Now, bone damage. This is something that 80% of patients with myeloma will experience throughout their lifespan. Some studies are saying now that that's a higher number, over 90%, because we're using PET scans and MRI imaging. And in the past, we only really used bone x-rays from head to toe. It's important to protect your bone health by maintaining a healthy nutrition, a well-rounded diet, weight-bearing activity, and make sure you discuss with your healthcare provider if you should be receiving calcium and vitamin D, bone strengthening agents such as denosumab, zoledronic acid, and pomegranate are all very important to protecting your bones for future fractures. There's many different ways to give these medicines and many different reasons why you would get one over the other, so talk with your team. But in general, most will give you these medicines monthly for about a year, 12 doses, and then go less often, depending on how your bones are and how well the myeloma is controlled. It's very individualized. New pain should be reported immediately to your healthcare provider, and it might not be myeloma related. It might be arthritis or a pulled muscle. So we might do some imaging, but in general, most patients can do quite well. Peripheral neuropathy, as I mentioned before, occurs when there's damage to the skin organ and your brain perceives that. So it can be the skin organ. You can have numbness and tingling, prickly sensation. It can also affect your motor or your large muscle groups and have problems walking. So it's important to report any new numbness and tingling or leg or arm weakness to your healthcare team. If you're on bortezomib, we can give it as a shot under the skin. That'll lessen your chance of neuropathy, which is how we generally give it for most people these days. Or you can give it once weekly, which is what we do a lot of times in my practice. It's important to make sure you don't say, oh, you're on bortezomib. It's probably neuropathy from bortezomib. I always rule out other causes such as vitamin B deficiency, thyroid problems. So there's things that we can look for as healthcare providers. Uncontrolled diabetes, that can cause more neuropathy. It's safe to take, in most cases, a B complex over the counter, folic acid, but some medications we should avoid on the day of the bortezomib or Velcade infusion if you can. And make sure if you can't feel your feet, you're having a safe environment with throw rugs are, they're patted down to the floor, wear well-fitting shoes, and watch out for barriers or furnishings in a way. And again, if your neuropathy worsens, there's medications we can prescribe to tell your brain to be less aware of the neuropathy. Viloxazine, gabapentin, and pregabalin are some very common ones as well. And then finally, I'd like to talk about pain prevention, and pain management. Pain can significantly comprise your quality of life, and it can lead to a lower quantity of life. If you're sitting in the chair because you have back pain that hurts when you move, but you don't feel like letting anybody know about it, then you can get a blood clot, and then that could be in a whole other problem. So we don't want you to have pain that goes unmanaged. There are a lot of sources of pain, so it doesn't mean that the myeloma is active if you're having new pain. It could be from the bone disease, it could be from neuropathy, or from medical procedures. We have lots of what we call adjunct medicines to treat pain that might not make you tired or feel bad. Bone strengtheners can lead to decreased fracture risk and help your pain in that way, protecting you against that. And the intervention depends on the type of pain. A lot of times we'll start physical therapy for some worsening low back pain. The lumbar canal might be narrowed, so we want to strengthen the muscles and tendons that support the spine through physical therapy exercises. You'd be surprised how helpful that can be for some people. But by all means, tell your healthcare provider if you're having new back or bone pain, and maybe massage or acupuncture would be right for you to help control that symptom. So at this time, I want to take another moment to thank you for joining me and remind you that you're not alone. The IMF is there. You should have nurses, doctors, and a whole healthcare team that wants to help you get through this. At this time, I'd like to pause and ask if there's any questions. I'd be happy to answer them. Thank you.
Hey, Beth, it's Kelly Cox. How are you again this afternoon yet for you? Yeah, I believe it is. You know, you made a reference towards Star Wars, and that's one of my lines I always say, that all these terms look like they're out of Star Wars. So just take your time when you're reading them and make sure you go to your health professional to understand them deeply. I forgot to mention Joe, is it Crowley? Yeah, Joe Crowley of the Montgomery support group. He does the myeloma networking group there, and he does a fantastic job. So I covered all the support group leaders, and of which, to you leaders out there, this would not be possible unless you went out to the fields and got things planted and harvested people and so forth and so on. So let's see, we do have some questions. Was there one? Okay, are routine dental appointments advisable for MM patients given the COVID environment? Beth? Having a little technical difficulties here. I would check with your provider to find out about the dentist. I have noticed, well, at my dentist here in the Los Angeles area, they are wearing the PPEs, the mask over their face, the shield over their head. They've got gloves on and doing even more cleaning than I've ever seen in a dental office. So you just want to make sure your dental office is prepared for protecting you against COVID, as well as you can't go in there with a flu, sneezing, any of those kind of bone chilling events there, because you don't want to spread anything that's possibly there. Beth, are you back yet? Okay. Now, I have some other questions. Dan, what about polio as a bone strengthener? What kind of side effects? Dan, we've had a little technical difficulties here with Beth. I would suggest that you email that to our info line at myeloma.org, our info line at myeloma.org. I keep hearing, is Beth on? Oh, there's Dr. Costa. How are you, Dr. Costa?
Hey, how are you? I was here in the background, but I know it seems Beth is having some problems. I'll be happy to help answer the questions.
Okay. Are routine dental appointments advisable for MM patients, considering the COVID situation?
I heard your answer, Kelly, and I couldn't agree more. It's very important to prevent infections, to keep a good dental care, so you're preventing osteonecrosis of the jaw for patients on bisphosphonates and other bone modifying agents. So as long as your dentist is keeping those practices, and they all are, I would encourage the patients to keep their appointments.
Okay, that's good. Now here's one, I might not be pronouncing it correctly. What about Prolia as a bone strengthener? What kind of side effects do you know?
So Prolia, if I'm not mistaken, is denosumab, which is the same drug that is on Xgeva. So there are bone modifying agents, very much like zoledronic acid or Zometa are a bone modifying agent. The only difference is it does not cause renal dysfunction, so it's safer for the kidneys. They are equally effective in preventing bone disease and prevent fractures. However, they carry the same, if not a higher risk of osteonecrosis of the jaw. So it's an adequate therapy, but it's also important that the patients maintain good mouth care and proper dental care.
So that's a good thing to do. I think even the caregivers have to remember to go to the dentist. Dr. Costa, I had another question from one of your topics. I'd like to ask that now. He said, my mom is still using Melphalan, and I think she's been 3 times or so in relapse. I'm confused. Is the Melphalan causing the relapse?
No, the Melphalan doesn't cause the relapse. The Melphalan is an agent that is used to treat myeloma. is that nowadays there's very few regimens that we use that contains melphalan. So I think it would be, and we almost never repeat melphalan in low doses except for additional transplants. So I think it would be important to somebody who's being treated repeatedly with melphalan as part of a regimen. It would be important to discuss with the provider or seek the opinion of an expert or what other regimens would be available.
Excellent, excellent, excellent way of saying that. I really appreciate that. I notice that I'm running a little tight on time here right now. I want to thank you, Dr. Costas, personally for doing this. And if you tell Kelly the same thing, and Beth, if you ever get back on, I want to tell you how much I appreciate you.
Thank you, Kelly.
All righty, let's go to the next slide. This would not be possible without the sponsors Amgen, Janssen, Binding Site, Bristol Myers Squibb, Karyopharm, and Takeda Oncology. It's with these people's approach and participating with these talks that ultimately helps the patient. I wanted to go over two things or so. You know that you can get whatever you want at Myeloma today. You can't get cheeseburgers or hamburgers, but you can get knowledge, and knowledge is power. You have a phone number to call too, and that's 800-452-CURE, and CURE translates to 2873. We also have the info line at infoline@myeloma.org, where you can get your questions answered, and they're really a great group of people. It was mentioned earlier about the Icelandic studies, and that's under our research division of Black Swan. You want to find out about that at myeloma.org. Sponsors, and then the Comedy Roundtable Read. It's the Ray Romano and team from Everything About Raymond. Everybody loves Raymond. Gosh, I'm sorry, I should have known that. And that's going to be on Friday, October 23rd, and it's a table read. Go to our website and you can participate. These are very, very funny people. The next RCW is going to be November 13th. We call it our Southwest RCW, and we'll have Dr. McHale and Dr. Panner from Rush University. I highly suggest that you join in on that one. It will be on our website shortly, and you'll be able to participate. And with all that being said, I've talked a lot, and I'm going to let it go over to video, and we're going to round up the day. I appreciate everyone's time. And Amira, if you'd roll the video.
When a patient is diagnosed with myeloma, they're not alone. They have support. They have information. They have access to things that were not there in the past.
After seeing the ravages that myeloma can cause, since then it's just been a mission to not have other people have to go through and suffer what he did.
There was a desperate need to provide information that could lead them to the best tests and to the best treatments.
It was just giving patients the voice.
We needed new treatments, better treatments. Could we cure myeloma, prevent myeloma?
Sometimes a very big advance can make only if you take a risk.
Look what happened in the survival of patients when the IMF started, and now 30 years later.
They achieved so many things in these 30 years, the focus, the energy, the synergy.
It is almost impossible to believe what has happened over the last 30 years.
The outcomes are dramatically improved, and they're going to improve more.
Because we believe that we can work collaboratively and we will cure this disease once and for all.